recording.
Thank you very much to the organizers for inviting me to give this talk. So here are my disclosures. So what I want to share with you is our work on the next generation imaging. I'm going to talk to you about the radiomics framework to accommodate multiple cancer types, but with an example in ovarian cancer. How we have done some work in refining treatment response assessment and the outcome prediction in the neoadjuvant setting. And I'm going to particularly spend some time on automated whole volume tumor segmentation, as well as the multi-omics data integration, which is really key to improving the outcome prediction. I'm also going to talk to you about the tools we've developed to dynamically track this tumor heterogeneity over time, following neoadjuvant chemotherapy in ovarian cancer. And we developed novel tools to guide the biopsy prior to treatment using ultrasound, but also at surgery when we harvest the tumor using 3D tumor molds. And I'm also going to show you how we are going to, or we have already implemented this in our novel clinical trials in the neoadjuvant space, but as well as in the window opportunity studies. Just a little bit about high-grade serous ovarian carcinoma. It is a difficult disease to treat. The outcome hasn't changed the last 20 years, despite new drugs being developed. And one of the key reasons is that we really don't know or can currently accurately measure treatment response and really detect early resistance. And what is the main reason for that? Well, the main reason is that disease is extremely heterogeneous from the genomic point of view. It starts at the fimbrial end of the fallopian tube, which is open to the peritoneal cavity, so immediately is metastatic at presentation, with the first port of metastasis being the ovary, but then instantaneously spreading into the peritoneal cavity. So it's an early spread to the abdomen as a multi-site disease. There are no actionable oncogenic mutation. However, it's got a high, complex, and chaotic genome, mainly driven by copy number alterations. And thus, there is clonal evolution, which then drives resistance to treatment. So what I'm going to focus on is how do we transition from this qualitative assessment of imaging interpretation? I'm going to concentrate mainly on standard of care CT, into really more quantitative assessment of disease, how we develop tools for tumor segmentation and radiomics and habitat imaging, how can we quantify this intertumoral and intertumor heterogeneity in space and time, and ultimately, which is key, how do we integrate the clinical imaging and molecular data on a patient-by-patient level? Those are all challenges which we've attempted actually to address in our research group and through multiple collaborations. So let me just take you to an example. I'm an imager, so I look at the CT scans day in and out. And if I'm presenting with 3 patients like this, when they come for the first CT scan, you can imagine there are 2 next lesions here, right and left in each patient. And as they come for the second CT scan, my role is to actually measure those lesions and then assess the response. Are they growing or are they shrinking, and by how much? And I can assess the RECIST category. And it's fairly easy to assess the progressive disease category because the lesions are unequivocally grown. So that's not a problem. Luckily, it happens rarely. In about 20 to 30% of cases, don't respond. It's also fairly straightforward to categorize patients to complete or partial response, and the majority of those patients do that, which is also good news. However, in a insignificant proportion, as much as 30%, we categorize stable disease, which is a category we put patients because we don't really know where they belong. You know, most of them will be probably partial responses, and some of them even progressive disease with very little true stable disease. And the reason we can't do that is our current methods are actually inadequate because we use a ruler, we measure a dimension on a disease which is very irregular in shape and form and permeative throughout the peritoneal cavity. And also the CA125, it lacks time in terms of detection of the progression later or the regression. So it's a lag in time in the CA125 response. So where we want to be in about 5 years' time or 10 years' time, or even sooner, actually, hopefully, it's in a space where we can integrate all the information from imaging, from tissue, genomics, circulating tumor DNA, and truly, really categorize these patients, taking into account this tumor microenvironment. Are we dealing with even hot or cold microenvironment? How can we use imaging to actually really do a virtual biopsy, at least limit the amount of biopsies we do? So, in this disease, we have extraordinary heterogeneity between patients, within a patient tumor, between the sites of disease, and also within the same lesion. So we have the challenge of heterogeneity at 3 levels, but also we have an opportunity. Wherever there is a challenge is a great opportunity to develop these new computational methods to capture this heterogeneity in both space and time in order to really understand drug resistance. You're going to hear the concept of texture and radiomics throughout the talk quite a lot. And I thought I'll just very quickly give you an example of, and this is just paintings from Metropolitan Museum of Art in New York. And if you go from this Mark Rothko painting to this Jackson Pollock painting here, you see that the homogeneity is higher here compared to this painting on the other side. And the entropy is not quite, but almost goes on the other way around. So this is the same with CT. So you can assess the texture, the heterogeneity of the lesions in any imaging, being a photograph, a pathology photograph, an image. You know, in CT, you look at the grayscale. And then you can, it's important that qualitatively you can say that, but it's important you put a number, you can quantify the heterogeneity. And we cannot do that with the bare eye. We need a quantification method. And this is what radiomics is about. So we've now developed methods to quantify this heterogeneity, both in terms of intra, but also inter-tumor heterogeneity. As I said, there are multiple sites of disease, and combine this all together computationally. So what is this? This is showing you these 2 patients here with ovarian cancer. One survives better because it's more homogeneous disease. The other one here survives very little heterogeneous disease, despite less volume of disease. And just an example here on the early work we did at Memorial Sloan Kettering Cancer Center, though both these patients are of the same genomic subtype called the mesenchymal clover subtype, inherently associated with high resistance to chemotherapy, as much as 70%. Patient on the top here survives very well for ovarian cancer, almost 70 months here. Fairly homogeneous disease despite larger volume. Patient at the bottom barely, doesn't even survive a year, very heterogeneous disease. So even within this bad prognostic subtype, we can dissect patients in a better way. We did some work as well, again at Memorial, on immunotherapy setting for recurrent disease. And what we found was that more homogeneous the largest lesion was, and less sites of disease in a patient, better or longer durable clinical benefit. Again, data points out the same conclusion that heterogeneity matters, as well as multiple sites of disease. We combine this work together in terms of combining the Memorial Sloan Kettering cohort and the TCIA cohort, and we developed this vector which takes into account the intra radiomic heterogeneity, conventional clinical and genomic classifiers, and as you can see, this combined integrated information or parameter predicts the treatment resistant, platinum resistant much better than the conventional ones. So this was all retrospective work. Let me just take you to one case, which always is a single patient we've learned a lot. This is a patient with ovarian cancer, high-grade serous ovarian cancer, which underwent multiple lines of chemotherapy and chemotherapy holidays for about 9 years here, and is still well and alive. So she's at various sites of disease, including the primary tumor. And as you can see over time, they grow and shrink, they appear and disappear. And those are the 4 sub-areas that we had tissue over time, as well as the primary tumor, obviously, vaginal cuff around the liver, the right upper quadrant, and around the spleen. So the question we posed is, we don't really know the interaction between cancer, the host immune response, and the chemotherapy. And the analysis of patients matched primary metastatic disease is crucial for us to understand that. And this patient actually offered this opportunity. We know that metastatic tumors exhibit intra-patient heterogeneous tumor growth and somatic mutations pattern after multi-line chemotherapy. And there is a growing heterogeneity and clonal evolution over time. So this patient was ideal to actually try to understand, although being n equal 1, but having this sort of temporal course of the disease in multiple sites. So what we found was that actually the growing lesions, such as the spleen and the vaginal cuff, so as primary tumor, had higher expression of Wnt signaling pathway, so they're immune exclused, and the shrinking lesion was immune hot. So then we naturally posed the question, okay, how do this lesion look on radiomics, on texture analysis? And what was interesting was that the late, not just growing the shrinking, but the late metastases around the liver and vaginal cuff were phenotypically more heterogeneous on CT, as assessed by texture analysis. The natural question was, were there also matching genomic heterogeneity? Were they genomically more heterogeneous? Can we actually tell from imaging what the genomic pattern will be? And indeed, as you can see, the late metastases, such as the liver, vaginal cuff, have a higher number of mutations. So the branch of the tree is actually longer indeed. So although being a second case, we learned the lesson that in order to induce successful immune in the patient, you have to introduce successful immune response in all metastatic lesions. And really, the new treatment strategies that are designed, they have to take into account this heterogeneity, which we currently ignore, especially in multi-site disease. And we really have to be aware now that tumor response immunotherapy is microenvironment dependent. So with all that background in mind, as I moved to Cambridge, we set up this big radiogenomic group, which has grown, and it's amazing because it's got members from various disciplines, mathematicians, computer scientists, software engineers, and of course, radiologists, oncologists, and surgeons as well. We start off actually with the raw data from CT from the sinogram. And not that that can be immediately put in clinical practice, but it's interesting per se, because what we're trying to do is actually to develop mathematical models to reconstruct this data, that it becomes vendor independent and reconstruction algorithm independent, so it can provide a robust baseline to actually extract robust radiomic features. So we have collaborating centers feeding data through. The automatic segmentation happens, and I'll show you what we've done on that. The subtissue segmentation as well, and the radiomic features are derived. This is all fed in prediction algorithm along with clinical data, pathology data, and some of the pathologies actually sampled according to imaging. So we've got that matching of phenotype with genotype. So just a little bit on automatic segmentation. We've now developed, and is the first fully automatic ovarian cancer segmentation on CT, methods to automatically segment the disease, both in the pelvis and the omentum. This is such an example here. And as you can see, the automatic segmentation here being the blue line is as good as the experienced observers being the green and the red line here. So we also have incorporated an automatic tissue subsegmentation. We know that tumors are heterogeneous also to the bare eye. So this is that macroscopic heterogeneity that we can capture. And what is the most important information is coming from the solid part of the tumor rather than from the cystic or calcified one. And we really need to capture this. And Leonardo Rundo in my group has done a stellar work supported by Ramona Wojtek on designing this, not just for ovarian cancer, but also for renal cancer here. Important because you see the heterogeneity there as well. And this is just how the system works. And you can see our algorithms here perform very well and better than what's there out published. So once the segmentation happens, incorporated obviously the whole lesion as well as the subtissue segmentation, then we extract the radiomic features as I showed you, and we use this to predict the clinical endpoints, the progression-free survival and the overall survival. But just a step, earlier than that, we use it to predict treatment response. We also use this information by deriving those habitats that are based on orthogonal CT texture maps or MRI features, I'll show you later on, using unsupervised clustering to actually target the sampling and biopsy so we can understand the biological meaning of our radiomic features. So we texture maps, they undergo principal components to summarize these texture features and then spatial clustering to define these tumor habitats, as you can see here. The data set is integrated in our integration algorithms, and you can see here how rich the data is. We have clinical data, we have imaging data, we have treatment data, we have ctDNA data, and so on and so forth. And that our machine learning framework integrates all this data. We've used a training set from our perspective collection, the hold-out validation set. We use also an external validation set from Barts Hospital in London. This is our preliminary results. And as you can see here, what we're trying to predict is the volume shrinkage. And if you only have clinical data, your prediction is not very good. If you had the blood biomarkers such as CA125, it's a little bit of improvement, not much. The moment you have radiomics features, your improvement is significant. Your error is less, your accuracy is much higher. Adding ctDNA on this score didn't change very much, but adding radiomics really made a difference. So let's just go back to those texture habitats. I've showed you how we integrate the data for better prediction. Now we have a prototype that we can start implementing in clinical trials first, and then in routine clinical practice. But we also want to understand the biology. So we use this to actually guide our tissue sampling. And we do this with ultrasound. We've teamed up with Canon Medical Systems here, and we've done this in about 16 patients, and we've shown proof of principle. This is technically feasible. What we have to do now is actually to understand the biology behind it. Now we can sample the regions accurately. Now we really have to look at the tissue in more details. So now we have an established framework, and this is really important because we've inserted this in the clinical flow. And for one thing, for research to be successful, should not disrupt the clinical flow. That's for clinical research. So obviously the CTs are required in radiology, and the segmentation happens there. The all computation happens in our computational lab, and then the biopsy happens again in the clinical space in the ultrasound suite. Just to show you again that framework in a visual way. So radiology, tumor outlined. This is the texture metrics here, and then the fusion of the CT and the habitats. And this is what the radiologist will see in the screen. You see the needle going in here into the green habitat, and then the second pass will go into the red habitat. So this is all work on CT, and we've developed these tools to actually target those habitats on MRI too, but this is prior to treatment, prior to neoadjuvant chemotherapy. But what do you do at surgery to actually harvest the tissue so you can really track the change in phenotype and genotype over time? So that we develop methods to actually harvest this tissue in a way that we can guide the sampling via imaging. Here, in this case, we are actually combining MRI and PET to create those habitats. MRI, we're combining information from diffusion, so intracapillary perfusion, the perfusion part of IVIM, intrabox and Cohen motion, as well as cellularity, D, with tissue tumor permeability, K-trans, as well as the metabolism. The K-mean clustering is applied, and those habitats are derived. This is a primary ovarian tumor here, and this is the peritoneal metastasis. A mold is created based on the outline of this tumor, some tissue-weighted images. And each slice on this mold corresponds to a slice on the MRI. This is the arm of the patient here, and this is the tumor put in this mold. And this is sections to pathology. Half is sent to histopathology, and half is sent for genomic analysis. And here is the phylogenetic tree in this patient, the trunk, T53, it's ovarian cancer, actually. And then we have the two branches of the main branches of the tree. You can see how the yellow and the green habitat cluster together on one branch evolutionary, and the blue and the Amentum blue cluster onto the other branch. What is important to realize that some of the mutations which were subclonal in the ovary blue habitat became clonal in the Amentum blue, so the tumor is more aggressive. So now we can say that we can actually capture that heterogeneity with imaging, albeit this in a few patients. So really we have to do more patients. We've done a few more, just to show you another patient, just to show you how different patients' tumors are and in between sites. This is the pelvic mass here, you mentioned the pouch of Douglas, and again, the mold is printed, the team here harvesting the tissue, and then the histology and the multiplex IHC. We've looked at the data and looked at the various pathways, and again, limited number of cases here, but some important correlations, enough to make us really go and make it a larger scale, a well-designed study, which we've just started looking with MRI, incorporating carbon-13 rather than PET, for all-in-one physiological metabolic imaging of the multi-site disease. So stay tuned. So I'm hoping that what I've given to you is a sort of a glimpse of what we've tried to create in the last 3 years on tumor segmentation through a wonderful collaboration with a Department of Applied Mathematics and Theoretical Physics, as well as Alan Turing Institute and Siemens, on how to find our habitats based either on CT or MRI, and some elegant work we're doing on carbon-13 MRI in collaboration with GE Healthcare, how we can sample those imaging habitats to have a more meaningful tissue harvesting. And this is work in collaboration with the Department of Engineering in Cambridge, as well as the Canon Medical System. And also our 3D mold work to harvest the tissue at surgery. And of course, the data integration to better predict outcome. And some of this is in collaboration with GE and the Amazon Web Services. So it takes a wonderful team to achieve this. And I cannot be more lucky than I am with a wonderful team that we brought together, which has led to a lot of publications, but also a lot of fun. And this is our last get-together before the last lockdown, and we hope to meet again in the summer. But of course, it goes beyond the small radiology team to a larger team in Cambridge of various expertise to actually make this happen. And ultimately, important is to actually deliver the new paradigm of personalized cancer medicine. Thank you very much for your attention.